Is that the same review they were gonna do today?
I don't know. What today says.
Can I sit here without being?
You can sit right there, that's fine.
So the SU Epic review thing that's scheduled for next Friday,
Yes,
is
that
that
is
the same?
different.
Okay, it's different. Okay.
Different, yeah, totally different. So yeah, definitely come next Friday. You will want to go.
But the Epic review stuff that was scheduled today, now we just do on our own.
Yep, there's a sheet in Humphreys.
Is it the one that we've
Fill
done
it out,
every
probably.
semester?
Same thing.
Yep, yep, same
Yeah.
thing. So yeah, we just fill it out. And there's a chair up here, or you can sneak that one in down there too, that's fine. Alright,
Still
welcome
get your big head
to
in front.
fourth level. Everyone excited about the year?
A little nervous.
Nervous? Okay, understandably so. So I teach the critical care portion, so you'll be in the ICU with me. So we're gonna go over a couple ICU things. Dr. Fedorov is also gonna touch on some ICU things too. And that's for those of you who go to the ICU first before we cover some things in class. That way you've seen some of these things, we've talked about it, so it's not totally different, okay? So we're gonna talk a little bit about rapid sequence intubation and advanced airways, which everybody should get a chance to take care of a vented patient in the ICU. If your patient is intubated, they should have they will, not should, an ET tube. So they all come like this. They are different sizes. It says on the tube what size they are. This is an 8.5, usually like a 7.5 is pretty standard for an adult. It depends on the size of their neck and things like that. The physician usually lets you know, like what size ET tube do you want, and they'll tell you based on what their assessment is. You'll help more in the ER for intubations versus ICU. Usually in ICU, RT does most of the assisting and things like that, but it's just good to know what they're doing and supplies and things like that. So all ET tubes come like this. They are sterile. So you can open them, but usually you just set it beside the head so it's ready to go for the physician when they're ready for it. All ET tubes also need a stylet. And this one, of course, has kind of been run through the ringer over the years, but so they'll all need a stylet because when you go to intubate the patient, you want the stiffness of the stylet so the tube isn't flexible. So they'll put a stylet in, and so then they can also bend the tube to the curvature of the patient, so it will stay when they put the tube in. Once the patient is intubated, they'll take the stylet out. And RT, we'll use one of these, CO2 detector. So they'll hook this up to the patient, hook it up to the ambu bag, give the patient a couple of breaths. This should change colors if they're getting CO2 back, okay? Or, yeah, getting CO2 back. If they're not getting any change, they probably intubated into the stomach, so we'll have to start over. But you'll check for breath sounds, things like that. And then they'll take this off once it's in place, and they'll tape it up as well. Also, on the end of the ET tube is a cuff. You can shut that door if you want. It's loud. And so all cuffs need to be inflated. And there are certain pressure, I couldn't tell you off the top of my head. But you'll, usually RT does it, but you will, they will inflate the cuff so it sets in the trachea against the side of the walls. It helps prevent it from coming out, but it does not totally prevent it. Patients can pull these tubes out with the balloon inflated without an issue. So it'll need to be taped to them or some kind of securement device on their face to hold that tube in place. These things can pop or rupture, and so then you'll have like what they call a cuff leak, and you'll have to replace the tube. You can also, if you get this inflated too much, you can put too much pressure on the trachea and give them a pressure ulcer. So there's a certain pressure this tube is, or this balloon is to be at. Respiratory checks them at least every shift, but it's just good information to know. Questions on that portion? Okay. Of course, when you go to extubate a patient, make sure the balloon, you deflate it so you don't cause any damage to their vocal cords, things like that. But patients will pull these out. I mean, it's happened no matter how much you try to prevent that from happening. You'll have a patient pull one of these out. It's just inevitable. They're really tricky. They get pretty creative, and they can be super strong patients too, believe it or not. So once they get all hooked up to the vent, they will have tubing. So this kind of tubing will go to the ventilator. One's hooked up to oxygen, one's hooked up to just humidified air. And they'll get everything hooked up. This isn't quite the right connector, I don't think. Not quite the right fit. But this will go onto here. So it'll be hooked up then to the ventilator. And so then you'll have tubing come off from one end, and then this end will be closed. And then they'll be hooked up to an enclosed suction catheter. So the benefits of this is that all of this is sterile inside of this sheet. So when you go to suction the patient, you can just wear your gloves and you don't have to be sterile or anything like that. In this portion here, you take this cap off and you hook up to suction to the wall. And then you have this little thing here, which is an actual lets you suction. Push the button and it'll suck. If you turn it, it won't. So that just prevents, usually if you're not doing any suctioning, you want to lock it. That way, if in case they get unhooked from suction, you don't want to be suctioning a bunch of air that's not sterile into their lungs. So that prevents that from happening. They should always be hooked up to suction. Okay. And so then in order to suction the patient, you want to suction to the end of the tube. The thing is, you don't want to suction all the way. Usually people do make them cough. I usually go, because you really can't tell how far to go with these tubes. I usually go until they start coughing, and then I pull back before I start suctioning. Because when you go so far and you start making them cough, you're tickling their carina, which is like at the apex where the lungs split. And you don't want to do that, it's really uncomfortable. So just pull back a little bit and you should be where the tube is. And then you just start suctioning, like so, and pull it out, and that's it. You suction your patient. Some patients have thin secretions, some have a lot of goopy stuff at the end. But that's just kind of the down and dirty of suctioning. You can suction your patient. Usually I tell students that, do it with your nurse for a few times first, just to make sure they're comfortable with you doing it, and things like that.
You do it that quickly? Just kind of.
Yeah, you can, depending on how thick their secretions are. Some people like to do kind of like a squeeze and pull as you kind of do this. It helps prevent a little bit more of a suction. And if they have thin secretions, you can just pull it out because all those secretions are going to come up with it. If they're a little thicker, sometimes you might go slower to help kind of pull that stuff up out.
Can you just do it one time, or can you do it like 2 to 3 like you do trachs?
You can do it 2 to 3. It just depends on your patient. Now, if they're on the ventilator, you'll hit the oxygen button, the 100% O2 button. It'll give them 100% of oxygen for 2 minutes. So it just depends on how well your patient tolerates it. Some patients don't tolerate it at all, so you're going to suction them once, and that's going to be about it. Other patients, usually the norm, they will tolerate a couple times. It too just depends on how many they have, or how thick they are. If they're pretty thin, one time will probably get it, because you'll get them all at that time. These are changed every once a week at least, or if it gets really gunky on the inside, they need to be changed just for infection reasons, things like that. So I'll let you practice. I've got a few of them here.
Just like.
Any questions on any of that stuff?
After you suction, do you always put like normal saline?
So you might see people put normal saline down the tube. It is not standard practice. Standard practice, usually who you see do it is RTs, some of the older RTs, because that's how they were taught in school. They think that if you put normal saline down the lungs, it helps thin out the secretions, which is not true. It just makes the patient feel like they're drowning. You put a bunch of water in their lungs. But yes, that is not true, but you might see it. So, just FYI.
Should this always be locked when we're not suctioning?
Yes.
Okay.
It should be. Now, will it always be? No, somebody, might forget, but it should be always locked.
And how do you like it?
Pull out a little bit, and then you twist it.
You pull out and
Huh?
I feel like it goes up all the way down here. That's what it looks like.
Some other tubes or some other intubation tubes that usually you see maybe see is these usually you see in the OR. These are an LMA. What this does is it's essentially a blind intubation. They put it down and it sits. They put these down. This one's a fairly large one for an adult. But you put it down and then you air up the balloon. And what it does then is this sits on the trachea, like on your airway opening, and all of this blocks your esophagus. So then when you get breaths, things like that, it's going directly into the trachea. This has like about a 99% the first time accuracy, because it's just a blind. You just put it down, you set it in there, and then you pump it up. Usually they only use these if they're like a short surgery, like maybe 30 minutes or so, that way you don't have to intubate the patient and things like that. You can just put this in, and it's super easy. Some people in the field still use these, EMTs, things like that, if it's a difficult intubation, but you just never leave these in for long term. This is only a short term thing that you put in and then you take out. I haven't seen for a long time. A combo tube is another tube, and I don't have one of those. But it's also essentially a blind intubation as well. And what it is it kind of looks like two ET tubes put together. But they are separate, and you put it down, and one of them goes into the esophagus, and one of them goes into the trachea. And so it's one tube though, but you hardly ever see them because EMT usually puts those in, or paramedics for a blind intubation. You don't really need a lot of advanced training for that. And then as soon as they come to the hospital, they'd pull it and put down an ET tube if needed. Just because you don't want those in for a long period of time, just in case they may not be quite in the right spot since it is blind. But you don't see those very often anymore. I don't use them. Also for intubation, when you're setting up, this is a handle, this is a blade. On the back or on the package, you'll also always tell you what kind of a blade it is. This is a Mac 4 blade, and that's just the manufacturer and the type of blade. You can see too the difference between a Milwaukee and a Mac, how this one's much straighter with a small curve, and this is more curved naturally to the neck. This is the most common blade that physicians use for intubation. Your job can be to get this ready so it's ready to go. All you do is snap that on there and you flip it up, and the light will automatically come on once you flip it up. And you put it down and the light will go off. So essentially you can put this together, have it laying next to your tube, and then the physician's ready to go with it. The majority of these blades now are disposable. You should throw them away when they're done. We used to send them down to sterile processing, and they would clean them. We'd reuse them, but nowadays most of them are disposable. You just trash it. Physicians can also use a glidoscope, which is essentially a camera on the end. And what they do is they have a special blade and everything for that. It's got a cover on it, and they'll see right into the throat and see the vocal cords, and then just pass the tube with that, and which is really pretty simple to do. So you can mess with that. Only one handle though, so. And when you put it together, you're gonna put it together kind of almost side by side. Yep. Oh,
How,
other way.
sorry, how does this work?
Yep, just like that, and then just pull hard. Nope, harder. Go back down. Go back
Okay.
down together. Here.
Sorry.
No, you're fine. So you're gonna go, and I'm left-handed, so I apologize. So you're gonna go down like this.
Okay,
Just gonna
click
click
it
right
and
on,
then
and then yep,
pull
you're gonna
back.
hear the click, and then you're gonna pull up. It's okay. Yeah. And two, if you're working like in an emergency department, things like that. Most emergency departments, I know the one I work at, we have like a intubation box, which is just a tackle box full of all the supplies you need for an intubation. So you just grab the box, put it in the room, it's got everything you need, it's got tubes, it's got syringes, it's got blades, it's got lube, everything you could ever need for an intubation. And then you just restock the box and go from there. So it helps just to keep everything together. So you're not trying to scramble for supplies. Any questions so far? No? Okay. And everybody knows what an ambu bag is, right? Correct? This is an old ambu bag, so I apologize. We don't come across these very often to see one. This one is a little bit different. It's got this end on it. I'm not sure why. But so that's how this your CO2 detector can go on, and then you'll give the patient a couple of breaths, and you want to make sure you see the color change.
What did it change to?
It'll change to yellow. Right now it won't change to anything. But when you give them a couple breaths, when you let go, it should they should blow off CO2, so this will change to yellow. And every time you do that, it'll go back to purple, and then it'll change back to yellow. And if you don't see any color change, then you're not in the right place, and they'll have to pull back and try again. You'll also check for breath sounds. They'll get a chest x-ray to make sure it's far enough in and not touching too close to the carina or anything like that as well. And then you take them off all this, take this off because you don't need it anymore, and they'll hook them up to the ventilator. Okay? Let's see. Okay. So we'll talk a little bit about code blues. I do not have a crash cart with me, but in MediMan, you will get to mess with the crash cart. And so there should be a crash cart on every unit in ICU. Usually there's 2 or 3. It just depends. There's usually one. If it's a large ICU, there's like one on each side. It should always be plugged in, the defibrillator. Usually it should be checked at least twice a shift, if not once a day. Usually there's a designated person, like the charge nurse checks it every day. In the ER, our trauma nurses would always check them, because that would just be their job in the morning to go around and check them, or at night when they first start. All crash carts should basically be set up the same. It kind of depends on the manufacturer of the cart, but most of them should be set up fairly the same. There's always the defibrillator on top. All defibrillator comes with pads. And of course, if it's an emergency that you know that's coming, you want all this out and ready to go before the patient gets there. Actually, we'll have this all hooked up to the defibrillator before the patient even gets there, and then put the pads on when the patient gets there, that way it's ready to go. They make them super easy nowadays. You just look at the picture, it shows you where to put them. Slap them on, and then this piece hooks up to the defibrillator. Now the thing about this piece You have to make sure that your defibrillator is on the correct setting for actual defibrillation. You can also hook a patient up on the defibrillator with leads, so they can have a 3-lead, so you need to make sure that your setting is on the pads. So all that'll be on top, suctioning will be on top as well, and it should all work, because someone should check it every time. And then you have your cart. The first couple of drawers, it depends on where you're at. One will be a medication drawer, so either the top or the second drawer will be medications. Crash carts are always locked. There's some kind of locking device that's on the front, so not everybody can just come by and open it and get supplies out. That way you know someone has checked this cart. It is locked, so it has everything in there that it's supposed to have in there. So if you need to ever get into a crash cart, you have to bust open the tag to open the door and get the drawers out. Because they will charge the patient for that cart then. That's kind of how they bill the patient, is then by the cart. There's usually someone that's designated to check the carts if you've broken into one. Usually like RT, respiratory therapy, will come get the cart, bring a new one down, and have it ready to go. So once you bust open the cart, you can pull out the drawers. When you pull out the medication drawer, that drawer is also locked. All the meds are locked, because that's a different charge for the patient. It's all about billing. So you have to pop that drawer too on the inside and pull that out so you can get to the medications. Because if you just pop the crash cart but you don't pop the meds, they won't charge the patient for the med portion. Crash carts, they have a little bit of everything in them. They have some IV fluids in them. They have tubing, flushes, labels. Some of them may still have a code sheet in the bottom drawer. Some facilities still use a hand code sheet. Personally, if I'm running a code, I want to write everything down. I cannot find every little piece that I need on a computer. It's just easier to write it down and go back in and do it. That way, if there's a mistake or anything like that, you can just cross it out, write it, and keep going. It's just so much easier to write stuff down. If you're writing a code, usually the recorder is kind of the person who's in charge of the code. They are recording everything that's happening. Who's in the room? What's happening? Are they doing chest compressions? What's the rhythm? What's the vital signs? Is it time for more meds? Is it a pulse check time? Things like that. Were they intubated? Did someone put in a central line? All of that is done by the recorder. So that's kind of their job, to be in charge. Sometimes there should be a physician that eventually shows up to a code. Usually they are in charge, but the recorder needs to usually be a fairly strong personality, because they're going to need to be telling the physician what's going on, what's happening, and what needs to be done. Because if you're ACLS certified, you can give meds, all that stuff, without a physician present, because you have the certification. So, medications that come in the cart. Epi, there's only so many doses of Epi. They all come in a box that looks like this. Sometimes you will run out of these pre-dose boxes. There is a small vial of Epi that's in there too. So you just need to pay attention on what it says per dose, so you don't give the whole vial, because it's a multi-dose vial. I think it's got like 10 doses in it, which is 10 mLs. This is also 10 mLs, but it's only 1 milligram. So you have 1 milligram and 10 mLs, and you have 10 milligrams and 10 mLs. So if you draw that whole thing up, you don't want to give all 10 at the same time. That will not be well for your patient. So Epi is about, not the only thing in there, but there's usually Epi in there. There's atropine in a box as well. Sometimes there's lidocaine, D50, bicarb as well, and they come in these big boxes, the D50 or D5 and bicarb. And these are all emergency medications. Amiodarone will be in the cart as well, and then just some odds and ends stuff. With that multi-dose vial of Epi, you can start an Epi drip. Within the crash cart, they've got everything labeled so well that they've pre-made labels of exactly what you need to mix with what to start an Epi drip and put it together until pharmacy can get you one. You can do that with dopamine and Levophed as well. So, take one of these and pass them around. We're going to put these together. Most of them are already opened, so just be careful. They do have needles on them. everybody got one? Okay. So you can see where it's easily accessible. It's all perforated at the bottom. You open it up. Some of these don't even have stuff in them anymore. And so then you have the 2 yellow tops, and each of those yellow tops pop off. This one's really old. Okay. Does it? Oh, this one's not even right. I just need to toss it. Get this one. Okay, there we go. Okay, so then you have the blue portion, and what you do is you stick on the blue and you screw it on, and that screws in. And then what you do is, don't take the green part off, because it's got a needle under it. What you want to do is hold the green part and unscrew this, because this green part, for some reason, they still make them to where there's a needle, in case you do work in a facility that still uses needles at the bedside. So you want to make sure to leave the green part on. And so then you're going to put all this together and you're ready to go. And so there's always going to be one person that's in charge of meds in the crash cart and one person that's in charge of the actual crash cart itself. So there's one person that's running the defibrillator while one person is getting meds. Another person will be giving the medications. So that way you can start getting things ready while that person's giving medications. So you'll hand this to whoever's giving meds, and you'll tell them exactly what it is. This is 1 milligram of epi. And they'll repeat it as well so the recorder can hear it. That way they can record what's going on.
How many people are on?
There's like in a code,
Yeah.
a lot of people. That's why if you get a lot of people in there because you have someone who's running the airway, chest compressions, the cart, the meds, giving meds, the recorder, and then the physician. You get in the ER rooms. The ER rooms are about this size. So you get that in, get a bed in here with a crash cart and a patient. If I'm the recorder, I'm usually, if you do not have a job, you need to get out. Because you are taking up space that we can't move around, we can't see what's going on. So that's why you need a strong personality who's going to say get out. I mean, that's just usually your job. Because it just gets too chaotic in there. It's already chaotic. If you've ever seen a code, it's very chaotic, but it's usually pretty organized chaos though. Someone's usually in charge, but there's a lot going on. And so whoever gives that, and then you can toss this in the sharps or keep it. Usually we keep everything that's given. That way we can see exactly what was given, and sometimes they need to scan them into the computer as well. So we keep everything. This is considered 1 amp of epi. Anything that comes in kind of these boxes is considered an amp. So this is 10 mLs. Yeah. This is 10 mLs and it's an amp, and this is 50 mLs, I believe. Yeah, this is 50 mLs and it's an amp. So you have to know what medications you're giving. If they're saying go ahead and give an amp of bicarb or give an amp of D5, because these are both amps. It's just they're very, very different in the amount of stuff that you get.
I don't know what I did, but I'm dripping.
Oh, you may have. Who knows? It's just water. It's not any meds. Just be careful because there's a needle on there. These big ones, they go together exactly like the small ones. The thing is about these big amps is that because the resistance of the needle that and this one's old because it's got a needle on it still. The new ones are all like those. You can't push this very fast because just the resistance of the IV. You've got this huge tube versus something that's very small. So this will just need to be put in a little bit slower. But for code blues, normally the only things that you give are epi and amiodarone for the most part. Epi, that's what they do anymore. Any questions so far? Y'all are pretty quiet. Okay. Let's see, we're in part 2.
Lost one.
Does anybody work in the ICU here?
I work in the NICU.
Oh, with little people?
The littlest one.
I don't do little people at all. 0 for little. Okay, so everybody knows how to take care of a central line, correct?
No,
Do what?
I've never done it.
You've never done it, okay. But you've been taught.
Yeah.
Okay, so everybody's been taught on how to take care of a central line. Has anybody ever helped put a central line in? Okay, so in ICU you might help put a central line in. They make it so much easier than they used to. This is actually, I think, this is actually an older kit. I'd have to open it for sure. This one's a little bit older of a kit. Because nowadays they come like this, and like this one as well. This one's already open. Has everything you need in this kit. Everything. Drapes, masks, everything. So if they need to put a central line in, you just grab one kit. It used to be to where you have to grab a separate mask, a separate gown, a separate drape. Some physicians though do not like the gloves that come in these kits, which is fine. They're terrible, they're awful, they're like super plasticky. So they may request other gloves, which is totally fine. So that might be the separate thing that you need out of a kit. But you just grab the kit itself. And then they will usually do everything. You don't really need to do anything but stand in there with them and just help them if they need any help holding, things like that. The most places that they like to put central lines will be in the subclavian. Some people do put it in the jugular, it just depends. In the ER we do a lot of femoral, and the reason for that is it's quicker. The physicians can access that much easier. You don't need an x-ray when you're done because you put in the femoral. If you get blood back, you're fine. What's our concern when we put one up here? Do what?
Carotid?
Not necessarily, because they'll draw back blood, so they'll get back the right blood. What else is close?
The lungs.
Yeah, lungs. So what they're concerned about is a pneumo. You can give them a pneumo just by messing in that area in the clavicle and things like that. So before you use it, you have to have a chest x-ray. With the femoral, you don't have to, you can just go ahead and use it. So that's why the ER, usually it's an emergent thing that we want to give meds, something right away. So we're just going to go ahead and start a line down there. And then once they get upstairs, they'll switch it to something up high if they need it. But what comes in here, drapes, this is the gown for the physician. So you already have your gown in there. You might just need to help them tie it up.